Hello, everyone. I'd like to warmly welcome you on behalf of EHDN. My name is Kinga. I will give this meeting a couple of minutes so that attendees can settle in. So come and join us, grab a cup of tea, and we'll be in for a treat. So without further ado, I will pass this on to Anne Rosser, who will be able to say a couple more words.
Okay, yep. So my name is Patrick White. I'm the head of the EC, or the chair of the executive committee of the European Huntington's Disease Network, and I'm delighted. Thank you, Kinga, for the introduction and for setting up this this webinar, which is the fourth in a row of what we are hoping and seeing actually is becoming kind of a fixture of EHDN, of connecting with the community and reaching out and communicating advances in the field. And as Kinga already said, this is being led by Anne Rosser. So it's my pleasure to hand over the introduction of the attendees to Anne. Thank you for being here.
Thank you very much, Patrick, and again, welcome to you all. Very pleased that you could come along today. So as Patrick said, this is one of a series of meetings, and today we're going to have the opportunity to hear about and discuss the EHDN sponsored trial of deep brain stimulation in Huntington's disease. And just to say, for any of you who aren't so familiar, that deep brain stimulation is often shortened to DBS. So I'm sure you'll hear that during today's meeting. So the running order today is that first we'll hear about the trial from Professor Jan Vesper. And Jan is Professor of Functional Neurosurgery in Düsseldorf, Germany. And he was the lead facilitator of the EHDN surgical working group, where the idea for the DBS study was first conceived. And Jan then led first a pilot study and then a multi-center study of DBS Germany, supported by the German Medical Research Council. So for Jan's talk, there'll be a panel discussion. And just to introduce your panel, it'll include Professor Vesper. It'll also include Professor Håkan Widner, who's a movement disorder neurologist from Sweden and has long experience in functional neurosurgery and neural transplantation. Professor Joaquim Ferreira, who's also a movement disorder specialist from Lisbon, Portugal. And Joaquim has substantial experience in clinical trials in HD and other movement disorders. Miss Jessica Köhli, who's a Swiss-Venezuelan HD family member and advocate. And Jessica is a clinical psychologist, coordinator of the Swiss HD Centre and president of the Swiss HD Association. And we're all expecting to be joined by Professor William Gray, who's Professor of Functional Neurology in Cardiff, Neurosurgery in Cardiff, and Director of the Cardiff Advanced Neurotherapeutics Centre. So finally, following the panel discussion, there'll be an open Q&A session where you can put your questions to the panel. And so as I think King has already said, please put those in the Q&A session, because I think the function is disabled. So without further ado, I'll pass over to Jan Vesper. Thanks, Jan. So Jan, you're on mute.
Anne, thank you for introducing me, and so I didn't recognize myself, but thank you for this warm welcome, and I'm so happy and delighted to be able to present our Huntington disease deep brain stimulation study. So as you said, that is a result of a long-lasting collaboration with EHDN also with the CHDI, and was mainly funded actually by the German Research Council. So what we come later back on this idea, and so maybe for the beginning I can introduce you to the basic underlying idea how this feature came up. As we all know, so deep brain stimulation is very popular since 30 years for treating movement disorders like Parkinson's disease and dystonia, and also essential tremor. This is in the routine, well known. And since phenotypically Huntington's disease is somehow related to dystonia, so there were several attempts to publish case reports for deep brain, for successful and not successful deep brain stimulation in the globus pallidus. However, it was not quite clear whether it is the external or the internal part of the pallidum which has to be targeted, since animal results, especially in monkeys, supported the idea that that might be the external part of the pallidum, where what is more beneficial in contrast to humans to stimulate. And so the experiences from humans were more the internal part of the pallidum. And so the idea was in the beginning for the pilot trial to find out whether it is either the one or the other which might be suitable for larger trial. So these are my disclosures, and as you can see, there are some medical device companies, but also companies like Unicure, who is responsible for gene therapy trials, recently became available. So this is the main chart, a result of the pilot trial, which was focusing on the question whether deep brain stimulation in the GPI or in the GPE would be more beneficial. And as you can see, we had 6 patients, and they all responded very well for the first 6 months, except those 2. And in gray, and these were patients with Westphal variants. So we didn't exclude them, at least for this trial, for the pilot trial, because so we didn't know. So we didn't exclude them a priori. And so since they were presented to us, so we thought, let's find out whether it is beneficial in those patients or not. It is not, but the remaining 4 patients benefited a lot, and so that in the end of the day, this trial was successful in terms of Chorea and also in terms of the total UHDRS and also Burkitt-Van Masten dystonia rating score, as you can see here. So due to this positive limited results, so we intended to ask for a funding for a larger trial. These are still the adverse and serious adverse events. They were just a few with those patients. And of the Westphal variants, one of those patients had a malign hypothermia independent of surgery, so but during the post-operative course. So we published this pilot trial, the results of the pilot trial in 2015, and that was a time when we applied for as a larger trial. And finally, in the second round, we received funding from the German Research Council, and also as a partial support from the CHDI, but the main logistic support was definitely from the EHDN, and we are very indebted to the EHDN. Otherwise, it wouldn't be possible to run this trial. The idea as a flow chart of this trial was recruiting eligible patients with Chorea subscore of at least 12, and after fulfilling the inclusion criteria, so we wanted to have a baseline quite short to the final surgery. Patient underwent surgery and deep brain stimulation with a target. So I forgot to say, come back to this, I forgot to say, since there are no differences between GPE and GPI, we thought that there might be an evidence to target the silent zone in between the GPI and GPE, and this was finally the target for our surgery. So for our trial. After randomization, patients were separated in two groups. One group with stimulation on directly after randomization and a postoperative course for another 12 weeks, and the other group with stimulation off, operated the same way, stimulation off for this blinded period. After reaching the final, the primary endpoint, we decided to open it up to and with an open phase of another 3 months to have stimulation in both groups, and with a secondary endpoint after 6 months. So as a primary endpoint, the difference was a difference in change of motor symptoms against placebo or against best medical treatment in this off group, and regarding the UHDS total motor score during best medical treatment and on stimulation, as I said, 12 weeks after surgery. The secondary endpoints, we were focusing more on psychiatric cognition and on quality of life items rather than on motor items, but also the Chorea subscore and bradykinesia score, and also again Burke-Van Masten dystonia rating score, and obviously also the Q motor battery were interesting and for our secondary evaluation. Inclusion criteria where the clinical and genetically confirmed Huntington disease with at least 36 repeats. Only adult patients only, of course, a moderate stage of the disease, and as I said, a Chorea subscore of at least not 12 but 10. So my mistake. And then, interestingly enough, the Mattis Dementia Rating Scale, one above 120, which is interesting, and that was a quite hard criteria since many patients couldn't reach this 120 due to their motor impairment, and then we decided to go with 80% of the item, more than 80% of the items which were actually testable in those patients. And so because we wanted to prevent patients with very progressive mental disorder or cognitive decline to undergo deep brain stimulation for ethical reasons, and also for a potential if they reach their motor benefit, so it might not play actually a role for their quality of life. So patient has to have a stable medication for at least 6 weeks. That was the close baseline to surgery and, of course, informed consent. Juvenile Huntington's disease like Vesper variant with those predominant bradykinesias, we wanted to exclude them. Postural instability, of course, severe otherwise comorbidity, acute suicidality. So patient has to have a psychiatric consultation prior to surgery, and also of course participation in any other trial. And cortical atrophy grade 3, that might not be that popular, so I will later come back. That was a request from the German Research Council, because they said, so if the patient has a huge atrophy, how do you decide? And so we said, okay, we decide that we cannot plan a trajectory in this patient, and that was not enough for the German Research Council, and we were asked to come up with a grading, and since there was no grading, so we published one. So I come with a next slide back to this. And of course, coagulopathies and other medical conditions were exclusion criteria. This is an atrophy score. Lars Wojtecki and myself thought about to be published, and this is what we decided. Grade 1, no significant atrophy, mild atrophy, and severe atrophy. So that is quite simple. In the end of the day, that was sufficient for the German Research Council to, and that was the last border and limit we have had to overcome to finally get this funding after the third round. So power calculation was about 44 patients, basing on our pilot trial and also on the prevalence of Huntington's disease. And so in the few publications which were available at this time, and finally we had to implant 44 patients with deep brain stimulation for the final analysis. And we calculated to have 3 to 10 patients over a period of 2 years from each of those centers. The centers where I briefly showed this in one of my first slides among Europe, in France, in Switzerland, in Germany and in Austria, and unfortunately not in UK, but this was for legal reasons. So as you can see here, is a planning of a deep brain stimulation. This is not a Huntington patient, but a Parkinson patient, but that was 100% similar in terms of technique, draping, and so that I present you our OR setting very briefly with a Lexel system, which is available around the world in all stereotactic centers. This is an interesting tool here. So that is a so-called Ben Gun, that is a micro drive, which enables us to not just have one trajectory, but in a surrounding of this one trajectory of the central trajectory, like with a with the dice, with the number 5 of the dice, five trajectories altogether, to be able to record and microstimulate of this in the surrounding, and to find not just any target, but the optimal target for the particular patients. Those tiny microelectrodes are connected with a cable, which then is passed over the drape to the neurologist, and the neurologist will start with a recording that looks actually like any neurophysiological device for neuromonitoring. That's finally the ground electrode, and then you can see the other view, the next view, our neurologist, neurophysiologist, who are recording the micro discharges on each level, and also local field potentials, which you can see here online. And then we are also able to not just record, but also to stimulate. This can nicely be done also under general anesthesia. The patient is here under general. Since we decreasing a little bit the level of sedation to a level that the patient does not become awake, but enables us to record and stimulate quite nicely, also not only for effects, of course, but also for side effects. And this is the X-ray of the final electrode, which approaches here and final target. This is a fusion of the CT post-operatively with the preoperative plan. This is indeed a Huntington patient, and so you can nicely see that the electrodes passing by the huge ventricle, which is far more larger than normal patients. We implanted a regular conventional device from one of the medical device companies, Medtronic, who also supported the study by offering us the devices, since there was no reimbursement, of course, for deep brain stimulation, and they due to this support of the German Research Council, decided to provide us the devices as research devices. So finally, we included in the study 56 patients. A couple of them were not randomized for not meeting the final criteria. 2 patients died before randomization, not before due to surgery, but prior to surgery. And other reasons were 3 from withdrawal. And those patients, finally, we randomized 48 patients. And we had in those 2 groups, 25 and 23. As you might remember, we needed 44 patients. So there were 4 patients more in this concert diagram for the futility analysis in the end of 2018 to be presented at the Data Safety Monitoring Board. So descriptive analysis of this randomization process that just validates the baseline statistics. And as you can see here in the off group, we had 25 patients with a mean UHDRS of 25, and in the on group of 56, which is actually the same, and which was also true for the median and for the maximum value. So well separated in 2 groups. That's what we expected from randomization. And our primary endpoint after 3 months, most interesting point, with the descriptive statistics and the UHDRS total motor score after 12 weeks showed the following. So in the off group, we had this 25 I already showed you. After 3 months in the off group, we had a slight improvement to 51, which was not reaching the significance. And this was the same in the on group. The on group was 56 in the beginning and 53 after 3 months. So no difference at all between off and on. So that is the diagrams, the distribution diagram, and you can see there's no difference between red and green. So that was quite disappointing. However, if you see those charts, so you can see that there's a slight improvement in the off group, but also in the on group, and in the majority of the cases examined. So we had a tendency of certain improvement with 3 or 4 outliers who worsened during the follow-up, but both in the off group and also in the on group. That was hard to explain in the beginning, and so we want to have a look at this secondary outcome. The secondary outcome, as you might remember, was focused on the Chorea subscore and psychiatric items, cognition, HAT score, and so on. Let's see. In this Chorea subscore, so in the off group, we had a mean baseline of 16, and in the Chorea subscore after 3 months in the off group, not stimulated, of 12. So they improved. And this, in the end, was slight but significant. So how this could be explained? And they had no stimulation at all after 3 months. So and that was actually the same in this Chorea subscore in the on group. Slight improvement reaching the significance level. So, and if you see here the tendency that was even more pronounced than it was with the percentage of improvements is more pronounced here comparing to the total UHDRS. So let's go further. Depression in the secondary endpoint, no differences. The off group had a little bit improvement, but that was not true for the on group, but it didn't reach any significance. So in the end, so no more depression in the on stimulation. That was also true for the quality of life, clinical global impression score. So that was random, no difference at all. Then we wanted to evaluate the side effects. That was not that easy, and you can see that we just finished this evaluation. That was due to the fact that some side effects, adverse events were not constantly defined, but with different wordings, and so we have had to go to every adverse event from every patient through all the study to collect those and summarize this. So what you can see is that we have just one device failure, which was not a device failure, but actually following an inflammation and the mismanagement of reconnecting the device. So that was explanted, and actually no stimulation related severe adverse events. We had some due to surgery, which was obviously some infections, but local infections, just one of the patient has had to be explanted. A brain edema after surgery was finally decided to be procedure related, but that was resolved very soon. And that was also related to a hemiparesis. No severe hemorrhages, anything else. Far more severe adverse events in the Huntington disease group, and this due to Huntington disease, due to the disease, which were gait disturbances, as I said, 1 death, dystonia, and fall and so on. So, but to make a long story short, what is behind the curtain? When we have a look at the secondary endpoint and taking into consideration the whole group of our patients, we have to decide after 6 months, have to be aware that this in red is not the off group, because this is the off group from baseline to 3 months. After 3 months, they were anyway stimulated in the same way as the on group. So we have finally, after 6 months, an improvement in the total group in terms of UHDRS, a constant improvement of UHDRS, which was even more pronounced in the group which was stimulated later. Here, this so-called off group, but they were stimulated from 3 months to 6 months as well. And this is obviously the same for the Chorea subscore, even more. We have a constant improvement in the off and in the on group. And after starting stimulation in the off group, which was then the on group 2, they were even better than the total on group. And they still improved after 3 months. So these were the latest results. This is also true for quality of life, which improved here in the later stimulated group very nicely instead of the on group. So how to interpret the findings? In the intention to treat analysis, there was no statistical significant differences between the stim on and stim off groups in UHDRS total motor score after 12 weeks. So we missed our primary endpoint. However, both groups exhibited improvements in motor function, and several secondary endpoints, including measure of career, cognitive performance, psychiatric symptoms, quality of life, they all improved over time and within the 6 months. When performing an exploratory regression and correlation analysis, indicated that the baseline characteristics were particular measures of motor function such as true word reading and chorea severity, as well as the baseline quality of life assessments, and they were significantly associated in all those patients who improved with a degree of improvement observed at 3 months. Since no significant issues or surgical complications were observed, we finally thought that this is a potential contribution of a significant microlesion effect. Otherwise, it is not. We are not able to explain an improvement over 3 months in the off group, and that has obscured early differences between the groups. To interpret and to ask what is the future. So although the short-term blinded phase did not demonstrate any significant differences between active and sham stimulation or on and off stimulation, the overall data confirm now that pallidil DBS is at least safe and feasible. The observed association between baseline clinical features and subsequent improvements suggests that patient selection might be a key feature regarding outcome. Remember how we struggled with our pilot trial with finding the right inclusion criteria. And since the Chorea subscore is not that validated as to be a primary outcome tool, but may be in the future. So, and if we a priori would concentrate on this rare subgroup, of course, of cognitively stable, Chorea dominant early Huntington disease, we might and then have a longer outcome, a longer follow-up. So we might result in more clear result than in our trial. So especially with the, as I said, an extended follow-up and further refinement also of stimulation parameters. We stimulated with conventional parameters, which nowadays are not used anymore for our recently implanted patients with segmented leads and all those technical features which are now available, which was not available 10 years ago when we start to plan this study. So this is not a one-man show, and I'm just happy and that I'm able and invited to present those results, and I'm very adapted to also my co-principal investigator or neurologist here, movement disorder neurologist here in Düsseldorf, Alfred Schnitzler, to our steering committee, Ralf Reimann, Carsten Saft, and Lars Wojtecki. That was also interesting collaboration and a very good collaboration between two statistics centers, clinical coordinating centers for clinical studies here in Düsseldorf and in Marburg. One with statistic experience, the other one with deep brain stimulation experience. That was really fruitful. And also the centers in France, Switzerland, and other parts of Germany and in Austria, very adapted. Finally, this was also due to our data safety monitoring board, who had was really alert about this trial, and we are accompanied our study. And finally, the really hard work of our video raters in Toronto and in Aachen, Alfonso Fazan and Mrs. Rates in Aachen, Germany, so who did a tremendous job. The study wouldn't be possible without the German Research Council, of course, the research department of Medtronic, the CHDI, and especially the EHDN. And that was Bernhard Landwehrmeyer, who always told me when I was disappointed because somebody refused the funding for our study, that he said, okay, Jan, but just keep applied, just keep applied. And finally, he was right. And also about the referring centers, and I'm finally very indebted to the participating patients and their family who made this study possible. So now coming to an end, and stop sharing my screen. And I'm open now for any questions. Thank you, Anne.
Thank you, Jan. That was fantastic, really clear, and also gave us a beautiful appreciation of just how difficult and what a long road it is to do these sort of complicated studies. So really appreciate that. So while we bring the panel on now, I wonder, and while they're preparing themselves, I wonder if I could just ask you a question about the very intriguing idea about the micro lesions, and whether you're generally producing some improvement through placement of the cannulae, and I wonder whether there are other explanations as well. So I'm reminded about something Mark Pachansky said many years ago in terms of the transplant studies, and he was always very concerned about having a longer baseline because of the risk of people with Huntington's being very anxious at the baseline, performing rather badly, and then improving thereafter. I don't know whether you've had any further thoughts about that.
Yeah, so I also thought about the transplantation trial, and you know that I was also involved in the very early trials from transplantation. But the difference, the main difference, is that we not just infusing something which has a certain pressure and a volume of a lesion. Actually, we also in gene therapy want to fill up the whole target with as much as we can with this fluid and with this agent. So we, in contrast, we do not want to have so many lesions, and we never did actually 5 micro recordings in one patient because the atrophy of this of those Huntington patients didn't allow us to do this. So there were 2 or 3 maximum of those microelectrodes. But the main lesion comes from the macroelectrode. This is implanted, and it remains in the brain. And so, and as you can imagine, around this electrode, so we have a very small but significant reaction on an inflammation, like with any foreign bodies, even if it is sterile. So explanted patients, so one could measure this reaction, which is 0.5 millimeters in the surrounding of this electrode anyway. So by hitting the right target, there's an edema in our target structure, and we know also from other deep brain stimulation trials that there's a let's say a phase of at least 3 to 4 weeks until the patient is also under off stimulation as worse as he was before. So a significant microlesion effect was quite calculated before. However, with respect to the progression of the underlying disease, when we started to plan the study, we decided not to go over 3 months. Otherwise, we could have find the primary endpoint after 6 months or 12 months. So, but by validating the benefits with the risk of failing with the study, so we thought that 3 months might be enough. That is experiences from DBS in dystonia, how we finally decided it. But now after the study, so one can decide, yeah, next time we should go to the first plan and find the primary endpoint after 6 months.
Thanks, Jan. That's very helpful. Could the panelists please turn their cameras on? Thank you. So I'd just like to hear the panelists' views about the study, and in particular your thoughts about how the study fits with previous DBS reports, some of which have claimed more positive outcomes. And Jan, obviously very happy and keen for you to also chip in as you feel appropriate. So perhaps we could start with who's first on my screen. Joaquim, would you be happy to kick off?
Sure. And so again, thank you, Jan, for sharing data and for sharing data in this first overview that we have to that data. So first, it's a negative trial, so it's frustrating, and we are all, we are always expecting to have positive results and some positive expectation. That in that sense, it's frustration. My first comment is, was this expected? And what's the overview? Again, what were the data that we had before? And in fact, I felt that we were very ambitious in the way that you have designed the trial and in the way that we have designed your primary outcome, because your definition of primary outcome, it's the UHDRS. So you are expecting a benefit in terms of motor impairment, global motor impairment. So not just Chorea, but more than Chorea. And if we are fair, and if we try to look back and understand what was the best data that we had before, it's true, like Anne was saying, we had some, positive signals. But if we really do a systematic review of everything that we have done and it's public before, the positive signal were mainly on Chorea. At least it's my reading. Of course, in terms of what we want to do for our patients, we want to improve it globally. So not just Chorea, but again, all the motor impairments. So I understand your thoughts, but in fact, again, if we look back, the signal that was there was mainly on Chorea, and again, your decision to be more ambitious has a risk, and the risk is that probably, again, it's more difficult, and in that sense, it may fail. On the other hand, it's of course, again, at this stage, we need to analyze the data and see how conclusive is the data. And again, probably you have a positive signal again. So you fail in your primary outcome, but again, like before, you have a positive signal on Chorea. So in that sense, I would say that probably if we want to target again exactly what we have targeted, probably we may end up failing again. But I think the story is not over for the Chorea signal. And in that sense, that hypothesis, it's still open. The question is, DBS, it's not a pill. And when we look to a potential positive effect in an invasive therapy, the balance between benefit and harm, it's different from when we discuss just a 1-day pill, a 1 tablet a day, that it's clearly different. It's true that you conclude that this is feasible. That's true. This is safe. In some way, safety we knew already from mainly from the Parkinson field. But even when we say that this something it's safe regarding DBS, this means I would say at least 1 to 2% of serious adverse events. So it's safe, but really the harm side has this potential impact. And so if we have 1 to 2% of serious adverse events, this only can be moved to practice if the magnitude of the effect is really high. What again puts the emphasis on probably an effect that should be higher than what we would accept from, again, a more normal, I would say, oral administration in terms of therapy. So I would say that clearly, let's be fair, the trial is negative. The way we have designed it, your goals did not reached. And even the signals that I would say are still open, the question is the magnitude, high enough to justify, pursuing the same goal with an invasive therapy and with a disease that we know this is progressive. Last word on still, I would say, sociology of science. As researchers, we always try to find something that it's a positive signal. And in fact, your data at 6 months is, the 24 weeks, again, there seems something, but in fact, that it may just be placebo, and even Huntington disease has a high placebo effect. So we tend to say that diseases where we have also a cognitive impairment, the placebo effect may be lower. We don't know. So placebo effect still exists. The placebo effect, the lesional effect, whatever, I would not end up already in concluding that there is something there. There may be, we don't know, but again, that's our tendency as researchers to try to find something that would justify, pursuing the same goal. And I would be cautious. I'm not saying that that effect does not exist, but I would be cautious because it may be explained by things that are not related with intervention. So, and those are my first thoughts. And thank you again.
Thank you.
May I just repeat very briefly? Joaquim, you're fully right. So I didn't want to favor deep brain stimulation as the next best thing to do in Huntington. Deep brain stimulation didn't cure anybody, not even Parkinson patients. It just in maximums can suppress some symptoms. Whether it is Chorea or rigor in Parkinson or something, it didn't cure and has no influence on the underlying disease progression, especially in Huntington. Of course, it cannot. And you are also right in terms of this, even if it is a minimal severe risk. So you can just justify it if you have a robust data who are supporting the idea that you can go. So we failed the primary endpoint, so the study is negative. However, what I wanted to present is that there's something behind the curtain we don't know yet. And until we are looking for further biomarkers, so those studies under controlled conditions might be able also to help find electrophysiological, for instance, biomarkers for Huntington and support further trials. And also in terms of selection criteria, which in the end of the day, we wouldn't do the same trial again with the same criteria, of course. Of course not. So we would focus more, as I said, on more selected patients and to have it even closer. And and you know that we are from the beginning on also a priori focused on just a few percentage of the total Huntington population. That is, we never intended to cure everybody.
Thanks, Jan. Håkan, could you give us your thoughts?
Well, first of all, I must congratulate to complete a very complex study. This is amazing, actually, that it's been accomplished.
Thank you.
It is, of course, disappointing that the primary endpoint, but one can learn a lot, and I agree completely that there are more behind the curtain than the primary endpoint. I agree that what one can learn is its patient selection, I think, is important. The potential gains to be able to withdraw a lot of medication that result in quite a lot of sort of negative symptoms and is potentially very large to reduce very troublesome chorea. And if that is for a period of 5 years or so, I think DBS has a niche, but it's for a limited number of patients. And then how to really pick these, I think a lot of experience has been gained in this study that one really need to look into and perhaps design. It's always disappointing to say that you need to do another study, but and one can also discuss the target, and I think perhaps we come back to that. Globus pallidum is a large structure, and it's affected differently over time in Huntington's. We have just completed, not in Huntington's, but in another dreadful disorder, putting 4 electrodes, in 2 in the GPI and 2 in the GPE, and these can counterbalance, and perhaps that is a way forward. But again, it's a lot of information in this that will certainly help and guide us in the future.
Thank you, Håkan. Liam Gray.
Hi, I'm sorry I was able to join you late. We had some issues here which are now resolved, so I apologize for not being on time. Jan, I suppose a general comment would be the difficulty with all these randomized trials is that, you know, you may just be a little unlucky and statistics may not fall on your side. So I wonder if an approach of more Bayesian statistics in this area to look at a number of different studies over time might be of benefit. Do you have any thoughts on that?
Yeah,
Yeah,
so maybe we have to squeeze again the statistics. So we were always expecting better results. So so I think it's all about the selection criteria. It is not about the statistics. So what I understood also from power calculation and those thinks that this was the weakest point of our study. So it is not about the statistics. I have to defend a little bit our Center for Coordinating Studies. So they made it a really good job. So, and 100% humorless. But I think they can just trust on what you deliver prior to surgery. And if there's nothing there, or except case reports, it remains a little bit in the wood.
Yeah, no, that was exactly my point. Is that you can't.
Liam, we've lost you. Wait a minute. So could you say
sorry.
that again? Yeah, no, we've got you back again. Yeah.
Good. So no, that was my exact point. Was because of the way these studies are designed, because of the small.
Yeah.
I think we've lost you again, Liam.
Anyway, I guess I got the point. So next time, so if any studies like this will no, we can't hear you.
Yeah, Liam, we can't hear you. Liam, sorry, we lost you. Yeah, okay. Sorry about that.
Liam, so why don't you write it in the chat?
Too long. Can you hear me now?
Yeah, I can.
Yes.
Okay. No, I wasn't criticizing your statistics. My point, I wasn't criticizing anything. I was suggesting that a more Bayesian approach across a number of studies may identify the subpopulations that can benefit, and therefore that's a way of I suppose, looking at what your study contributes and adding it to what everybody else does to try and move the field forward. I wasn't criticizing you.
No. Yeah. I didn't took it as critic.
Good.
So I have the same point. So next studies with similar approach will definitely have better chances to be more precise, because they can take our data to validate their own selection process, right?
Okay. Did you have another point, Liam, or was that?
I did. I've also discovered what the problem was. I think Joaquim may be trying to get in. He's waving his hands. My other question really was to Anne about the placebo effect. Do we know if the placebo effect varies, or the potential for a placebo effect varies across the different stages of Huntington's disease? So you know, it strikes me that the risk of a placebo effect may vary with some of the cognitive and emotional stages that patients with Huntington's disease go through. So has anybody looked at this, or is it something that might be worth looking at?
So there is some data on placebo effect, and I'll bring Joaquim in a minute, because I think he's done some work on this. I don't think we know precisely how it changes over the disease stages, and of course, sort of pertains to one of the questions in the chat, which is about the the Q&A, which is about, you know, what is the expected deterioration in the measures. And of course, there wasn't a group in this study in which individuals didn't get the surgery. So I guess we know in terms of this particular study. But Joaquim, can I bring you in at this stage?
No, yes, and I will try to pick up again some of the issues that were raised. You know, the first one, statistics. You know, it's again, as I was meant, this is very human. We will try to blame something that it's not the intervention. Even we know that we can do, even regarding statistics, we can do it slightly different. Again, I don't want to enter on technicalities, but you have used in our comparison change from baseline. So 12 weeks versus baseline, and then you compare it in between groups. Probably even we can do different because this is a randomized study. We can even probably just compare the endpoint in between the two arms. Probably it will end up doing exactly the same, so the results will be the same. But there are some technical issues that we may even discuss regarding the population. For instance, let's think that there is a signal on chorea, and can this study be conclusive on chorea? Probably not. Even if you were clever enough to have a minimal chorea a signal to be included. So you have defined it on your chorea items in UHDRS, a minimum score. If you design this trial specific for chorea, I'm sure that you will include patients that will have a more severe chorea. So again, and again, Jan, and this again, clearly it's more ambitious to go for UHDRS global. And I would not see, we know less about using specific items of the UHDRS, but it would not be wrong just to have primary outcome as chorea, and probably the population will be different, and this merges with William. So if we do a trial just on chorea, the patient that will operate will be different. They will have a more severe chorea, and they be better candidates to pick up a signal if there is a true signal. So it's not statistics, is if we target chorea, the population will be different, and eventually we may have a better result. Regarding placebo, this is not a placebo study, just to be sure. This is DBS on evaluation versus DBS off. So both groups, we have the electrodes, so we have the lesion associated with the electrodes, and in both we have the impact of having a DBS technique. So both groups, ended up being, when they went to an operating room, they were operated, all the procedures were there. In fact, Huntington has a placebo effect, like, other neurodegenerative diseases, even cognition. They may improve with a placebo. What it's amazing, even when they have already a cognitive decline. I cannot comment on if the placebo effect has different magnitudes with different stages. I don't know. We don't know. But I would say that clearly Huntington, it's open to have an important placebo effect, even when we are measuring cognition, and that cannot be, again, this is something that we need to incorporate in our thoughts when we look to this type of data. Again, 24 weeks, it's still a short period. This is something that, again, clearly it can happen, and it can be that. The other thing that we have learned from other diseases, an invasive therapy may have a higher placebo effect. So patients were well cared. They went to eye differentiated centers. They were well cared. They were operated. So, invasive therapies tend to amplify the magnitude of the effect. And this also is something that may happen in Huntington. Even I'm not aware about that specific type of analysis, but it may be the case.
That might be in any study, so which is invasive enough to give the patient a well-feeling, a well-being for a certain time. So especially in the off group, since they were operated, they were not just not that off. So because it was not a sham stimulation, but they had real electrode in the head. So that is more a sham stimulation than an off group. And so that was also an ethical decision in advance whether we could really do sham stimulation, which is just a burr hole. But I don't think that would be possible, at least here in our region.
Okay, thank you. So I want to get to some of the questions from the Q&A, but first of all, I'd like to hear Jessica's thoughts, and you may also want to have give us some thoughts about what we should be saying to patients as well.
Well, it's very difficult because as a family member, when we hear that something is being studied, something new, it's been studied, of course, we have our expectations very, very high. And in this case, when we said DBS, it works with Parkinson, why is it not going to work with Huntington? I mean, it was really probably the expectations were very, very high, not because it was advertised like that. It was just like it works. So it's of course going to work with us too. Does that cause emotional distress? Of course, when we hear, oh, probably it's not like the way we thought it was going to be. So I think we need to be very careful from the associations and everywhere where we try to reach the patients, to recruit the patient, that we have to say it like repeatedly that it's a study, we're not really sure, even though a lot of patients understand. We have to try to not bring their hopes down, but not only like this high emotional, it's going to work, we need you, and you're not just a patient that, you know, it's going to be a part of a trial. So, yeah. But I do think, even though probably the results are not what we were expecting, I think it gives us, like everyone said, a huge amount of data. Where could we do better? What do we need to do? I'm not talking about the whole neurological things, because I didn't do any operations, but I do think that everything that could approach, that could preserve at least the cognitive function for Huntington's disease, it's of huge valuable, because that's where people most are impacted about the quality of life. And the motor skills, of course, they need to be, for quality of life, they need to be active, so they can probably have a really better quality of life.
Okay, thanks, Jessica. So just picking up on Jessica's point, and this might be something any of the panel members want to answer, do we think that DBS has a role potentially in cognitive improvements? There have been some studies in P, very experimental, I know, but any thoughts on that? Okay, I don't know whether, yeah, Håkan.
Again, it's
my guess is, oh, sorry. My guess is probably not that it actually improves. But if you could take away sort of competing factors that reduce cognition, for example, medications, sedative medications that could impair cognitive functions or alertness, or if you have a very, very severe OCD, for example, it's another target, but could really make a huge difference in the sort of overall function for a patient. So you can eliminate very disturbing symptoms and medications, and that may improve sort of indirectly cognitive functions.
Thank you. So we've got a few questions in the chat. There's one from Karsten Jan, and he says he's asked you this one several times before, so hopefully you prepared for it. He said, did somebody correct for the correct electrode site between GPI and GPE? Is it possible that this could have influenced the results? Jan, you're on mute.
Yeah, I already answered it directly.
Okay.
So in the chat, and so we didn't check the position yet, but it has to be done. That is not that easy, because so you have to recalculate every single postoperative CT or MRI and compare it with a preoperative targeting, which is, I mean, just 44 patients, but that's a year-long work to do so. And finally, we have to ask ourselves what will be the value of those data. I think a priori we should focus on publishing the main results, and this is what we're going to do. We are almost done with this first draft, and then we will circle it around. And this is what we are focusing on now. But maybe we have, I can find a student who's willing to do this, to evaluate all those stereotactic data, but it has a certain value, but to tell the truth, not in the first line.
Okay, thank you. So another question from the chat. Do you have any results on the Q motor outcomes? And I think there were some video recordings. Matt, you're on mute, Jan. Yep.
We do have from the video recording. This is what we try to publish in parallel to our primary result, and they basically confirm what we did, and it is really, really interesting. That is not just to see that this is goes in parallel with the estimation of the centers, but also the inter-rater variance is very, very small. That is quite amazing. But we will later focusing also on this. But the data are available. Yeah.
Okay, and again from the Q&A, you mentioned inflammation microlesions post-surgery. Were these monitored through some biomarkers in the 3 versus 6 month data sets?
Not really, not really.
Yeah.
So that would be hard to do. Because especially in the blinded phase, so the patient were sent at home and were not available every day. And so we didn't actually know how they do, and the rater didn't know whether they do have a microlesion effect or not. So this is maybe for another trial. One can prospectively focus on those issues. Sure, but it is the variability also among the patient is very high. Some had this and some patients not at all. So it's difficult.
Okay, and we've got a question about AI. Is there a place for AI? Is it being considered in new studies?
I don't have so much experience with AI, but maybe I could use an avatar to deal with our administration. So since I wouldn't do this again.
Okay. So
no,
so
I don't know. I don't know. Maybe serious answer. If one would use AI to cluster all the available data to come out with a new trial, not only deep brain stimulation, but any trial, so it might make sense. But that would be my idea about this, but no specific ideas.
So, Joaquim.
Now again, it's coming back to this AI suggestion, and it merges to the potential benefit of having all the data available, raw data from, Jan's trial, but all other studies with DBS, made available in a common registry, and then AI can play a role. Again, we may have negative trials with interventions where there may be responders, and this is something that we tend to forget. So. And this applies to DBS and apply also to medicine. Having a negative trial does not mean there may be some responders with factors that we have not identified, and AI may help us in identifying those potential responders. So there may be a gain of knowledge, yes, if we can first having all the data available, for academics. And again, this is in a meeting with where patients are attending and all the communities attending. This is really important because this is really a way to contribute, to progression of science and knowledge and all other things, and also to justify, the generous contribution of patients. And I'm sure that this is sought, but again, collecting all the data in a common database may be helpful, and AI may play a role on that. And so it's a good suggestion.
So thank you. So finally, this is to Jan and all the panel members. Do you have any takeaway messages? What are the takeaway messages that you'd like people to go away thinking about at the end of this?
What I wanted to do is to share another slide with you. I didn't show it you in my presentation. That's because I unblinded it. So that is to answer the question. Let me share it. Wait, where I do have the share button. Okay, here. Come on. So, can you see my screen now? Yeah, you can see my screen.
Yes, it's just coming
now
up
you
now.
can see my screen, and
yes,
I come with this. You know this already. That is the consequence of our doing, and is like searching for the philosopher's stone. And in 2017, I had the chance to ask John K. Rowling, as you can see her together with me on a charity meeting, and asking her about the Philosopher's Stone, and she told me that this is just a fairy tale, and I was very disappointed at this time. So that is actually my message to you, that there's no way actually of finding the Philosopher's Stone, the one and only solution with one trial. And we have more questions than we had before. Starting with the study, and the value of this DBS studies is limited. However, we did it, and we have the first randomized controlled trial in deep brain stimulation, and we can consider for the Huntington community that deep brain stimulation is not an approved indication. And as far as we can say, there is some processes behind, but I wouldn't go and recommend it to any patients, and also to those with
Oh, Jan, you've gone on to mute.
Yeah. Also with those with chorea symptoms, only in limited frameworks of the study that could be done maybe better than we did, but not for now as a general tool in the daily practice.
Thank you, Jan. Wise words and very helpful thoughts for us to go away with. So I want to thank you and the panel much indeed. We really appreciate the time and thought that you've put into this. It's an important study for us to discuss, and I think we've all learned a lot, and we can take these thoughts back to our clinic and to our lab. So before we actually finish, I just have some important but very sad news to share. Some of you may have known that Tim McLean had been seriously ill over the last few months. He bore this illness with his characteristic good sense and good humour, but today we learned the very sad news that he passed away in the early hours of this morning. Tim has worked for EHDN and for Enroll for many years and wore many different hats, but Many of you may have known him in this forum as the Clinical Trials Director of EHDN, where he worked closely with Jenny Townhill. And as well as being highly committed and incredibly good at his job, Tim was also a lovely person, a warm human being, and a really good friend to many of us. So he'll be sorely missed, and we send our warmest best wishes to his lovely family in Edinburgh at this very difficult time. So Tim, rest in peace. And on that rather sad note, I'd just like to thank you for all attending today. There'll be other meetings in this series, and you'll receive the information about these in due course. And until then, just wish you a very good evening.